So we don't have a lot of time, so we would just switch in and then move to today's topic. We would talk about inflammatory bowel disease, and then hopefully tomorrow we'll touch on another topic. Okay. I don't know if we ever heard of this medical condition, or we've read about it, or we've seen any case. It's not so common, but it's something that you should know, because you might have cases in your practice, and if you don't know about inflammatory bowel disease, you would end up misdiagnosing your patient, and you manage your patient for something else, like dysentery, whilst your patient has serious issues than just diarrhea with blood or phlegms in it. So it's very, very important that you know about inflammatory bowel disease. Okay. So let's talk about inflammatory bowel disease, and we would also touch on some of the, should we say, etiological factors, even though in actual fact we don't know the main thing behind its occurrence, but we would talk about some of the things that we suspect could be the cause of inflammatory bowel disease. We would also look at how it comes about, and we'll look at its presentation in terms of clinical features, and some of the investigations that you can do to help guide your diagnosis, and then also, in basic terms, what we can do as clinicians to manage patients with inflammatory bowel disease. So as the name suggests, the name speaks for itself, inflammatory bowel disease. So it tells you that the bowel has become inflamed, basically, or you have some inflammation going on in the GIT, or gastrointestinal system. And if you remember your cardinal features of inflammation when you were doing pathology, we said inflammation comes with pain, redness, swelling, heat, all those things that we talked about. So as we go on, we are going to see that some of these features of inflammation will be present along the intestine or the bowel, or depending on wherever you're finding this condition, you're going to have this features of inflammation present. And most of the time, once you're able to pick that up on investigation, that would help you in your diagnosis. There are two main types, or when we say inflammatory bowel disease, it's divided into two main groups. Okay, you have what we call the Crohn's disease, and then we have the other counterparts, which is ulcerative colitis. Okay, so as we go on, we'll get to know what Crohn's disease is, what are the specific features. When we talk about Crohn's disease, what we expect to see. We would talk about ulcerative colitis, specific features, and then also how to manage. So before we even go on, so this is a diagram that illustrates both Crohn's disease and ulcerative colitis. And when you pay close attention to this diagram, it can tune your mind to whatever we'll be discussing here today. It shows you the differences between Crohn's disease and ulcerative colitis. As we go on, we would talk about more details concerning the differences. But for now, you can see that when you take a look at picture 1, which is Crohn's disease, the red part, that's sort of the inflamed area. You can see that you some normal GI tract, then there's another inflamed part and all that. Whereas the ulcerative colitis, you can see that a whole stretch of the colon is basically inflamed. Okay, so as we go on, we'll come back to this picture again, but as we go on, we would get to know why and basically the difference between the two. So in terms of etiology, it's basically similar for both disease. We actually don't know the real thing. We don't know the real deal. Okay, so most of the time we say an inflammatory bowel disease is an idiopathic disease. So you don't know the actual thing behind it. Okay, but what we know is that people who have it tend to have a family history. Okay. Also, there's this hypothesis, which we call the hygiene hypothesis, which we'll talk about shortly. And also, it tends to have some sort of, excuse me. Also, it tends to have some sort of immune basis. Okay. I don't know. I think I'm having this irritation in my throat. So just a minute. I'll be with you in a bit. Yes. Okay. Sorry about that. So we were on etiological factors, and we're saying that even though the actual cause is unknown, we know that, I mean, there's some sort of family history there. And there's also a sort of hypothesis that has been deduced, what we call the hygiene hypothesis, which we'll talk about shortly. And then there's also some sort of immune response or dysregulation of the immune system related to its presentation, which we'll be talking about shortly. So what we know is that, as we are all aware, once you go into your gastrointestinal tract and all that, you have some form of bacteria in there. Okay, the body naturally harbours some sort of bacteria, what we call the normal flora. And sometimes you are also exposed to bacteria from outside, depending on what you eat, which gets into your GI tract. Once you have this bacteria getting into your GI tract, naturally, your body would have to react. Okay. So in that kind of reaction, your body will go through some sort of immune response, because this bacteria that is being exposed to your GI tract your body would have to make antibodies and all that. Sometimes you excessive or you end up producing too much effect on whatever is in there. It's like you seeing a fly and then you get a very, very big hammer or a mallet to crush the fly, whilst you could just hit the fly with probably a piece of paper and kill the fly. Sometimes there's an overstimulation of the body's inflammatory system just to some of the antigens that your body is exposed to. So this inappropriate response to the antigens that your body is exposed to would basically lead to excess or excessive inflammation. And as we know, even though in the right sense, inflammation is good because the process of inflammation is going to bring the neutrophils and whatnot to the site of damage to mop up, the effect of the bacteria and all that. When you have what we call, let's say, an exaggerated response or an exaggerated inflammatory response, you would rather have a negative effect on the system. And that is what happens in inflammatory bowel disease. Because we are having an inappropriate response to antigen from the foreign, substances or like the bacteria, your body is pushed into a certain mode where you end up producing too many inflammatory cells. You end up having to kill a tiny fly with a mallet. In the end, you are going to make excess cells. You are going to recruit lots of macrophages and all that. And this effect will lead to a serious inflammatory response. And as we are aware of, inflammatory reactions would come with pain. It comes with some sort of swelling. It comes with damage if the inflammation is excessive. It comes with redness. And because you are having an exaggerated response of inflammation, you are going to see an exaggerated effect of this inflammation. And that is basically what would present to you when you have an inflammatory bowel disease. So the symptoms that you see in inflammatory bowel disease is basically secondary to an inappropriate inflammatory response or a dysregulated inflammatory response. And of course, once the gastrointestinal tract becomes inflamed, then you are going to have gastrointestinal manifestations of inflammation. So there will be pain and whatnot. Okay, so we'll see some of the features shortly. So now that you are okay with the whole pathophysiology, let me also quickly touch on this whole hygiene hypothesis thing. And what the hygiene hypothesis, usually when you read, basically in summary, they are trying to tell you that depending on where you are giving birth to, you tend to develop some sort of, should we say, resistance or some sort of strength against certain bacteria that gets into your gastrointestinal system. So for instance, let's take two kids. One who, forgive me, is growing up at Choco and is always by the seaside, always playing all around. And you have another one who is at Trasaco Villa or something, who is always indoors, goes to some DB school and whatnot. Hygiene hypothesis will tell you that their exposure to microorganisms will be, in quotes, a cleaner environment, will be less exposed to microorganisms as compared to the one who is out there and about, environments are not so clean and all that. That person will be exposed to more microorganisms when you are looking at both of them in terms of their childhood. Now, once they grow up, because the other person who basically grew up in a dirty environment has been exposed to a lot of microorganisms, his system has built some sort of defense, unlike the other person who is in a rich environment and hasn't really experienced a lot of bacterial infections and whatnot. Okay, so with this, there's that perception that that person in a cleaner environment is more likely to have challenges. So the slightest exposure he tends to get later in life is going to produce an exaggerated response. And this is going to basically lead to that person having issues with the GIT system, unlike someone who has always had this bacteria and knows how to deal with it in terms of his system being used to it. That's what the hygiene hypothesis, once you read more about it, you would get to understand what it says. So Crohn's disease. So if we go back to our picture, you can see that the first one is Crohn's disease. Okay. With Crohn's disease, what we are trying to say is that Crohn's disease can affect every single part of your GIT from your mouth way down. Okay. Every single part can be affected. So when we talk about ulcerative colitis, even as the name suggests, colitis, you realize that ulcerative colitis is only restricted to the colon, whereas Crohn's disease can affect every part, okay? Every part. So it can affect way from your mouth to the anus. That's Crohn's disease for you, okay? So what is happening is that even though it can affect anywhere from your mouth to your anal region, you can see that the disease we would say it has a predilection for the terminal ileum and then the ascending colon. Okay, so basically that's it. There's what we call skip lesions with Crohn's disease. And if we go back to our picture, you can see that you have a part which is inflamed, then there's a normal part in between, another part which is inflamed, then there's a normal part, and there's another part which is inflamed. So we have skip lesions. So you have a lesion here, then a normal bowel, then it skips, and then, you know, there's another lesion, then it also skips normal bowel, then there's another lesion. So whenever you are out there and you hear people talk about skip lesions, you should be thinking, okay, could this be a Crohn's disease? Okay, so Crohn's disease would present with skip lesions, and basically what skip lesions mean is that you don't just have one area which is inflamed, you have multiple areas of the gastrointestinal system which is inflamed, but then this is not all inflamed through and through. In between the inflammation, you have areas of normal gastrointestinal tract or bowel, okay? So that's what we call skip lesions. So macroscopically, when you take a look at it, with Crohn's disease, okay, the inflammation is not only restricted to the inner part of the bowel. You know, when you take your intestines, the intestines would have what? A mucosa, submucosa, and then it comes all the way out, you know, all those things. Then it comes to the muscle layer, then it comes to the outside, which is the serosa, okay? So with Crohn's disease, the inflammation would extend beyond the mucosa, affects the submucosa, and it goes all the way out to the serosa, okay? So in Crohn's disease, we say that the inflammation is transmural. It doesn't only stay in the mucosa, it goes all the way from the mucosa and affects all the other layers and then comes outside to the serosa, okay? Once we get to ulcerative colitis, you realize that that is different because that is only restricted to the mucosa. However, Crohn's disease, mucosa all the way through to the serosa. So we say that the inflammation in Crohn's disease is transmural. Okay, so you are getting the differences. So usually when you take Crohn's disease and you look at the mucosa, you can see that it will present with very, very deep ulcers, okay? And then you have fissures. Fissures are like cracks in there. And the appearance of the mucosa would look like what we call a cobblestone. Okay, you know what a cobblestone is? You know those stones that they use for pavements. So after this slide, probably you would have to go to the internet and then get a picture to describe Crohn's disease. Also, because it's transmural or because it's going all the way through the mucosa to the serosa, you can develop what we call a fistula. Okay, a fistula is what? An abnormal communication between two organ spaces. Okay, so once the GI tract becomes inflamed all through and through, you can have sort of a perforation or a communication between the intestines and another organ space, and we say that that is a fistula. Okay, sometimes you could also have abscesses forming from that. When the disease becomes very, very severe, what we call fulminant disease, you realize that the whole mucosa is basically lost, and you just have few areas in the gastrointestinal tract or the mucosa, which even looks very, very edematous, okay, and also looks what's dilated. And if you remember cardinal features of inflammation, edema is part, so it's not so surprising that in severe cases, the bowel will look a little bit ballooned, and then the inner aspect, which is also inflamed, will look very, very, very edematous, okay. I think this is more of a schematic diagram where you can see there's a skip diagram and the stipulations. And then you can also see an inflammation, which is all through and through from the mucosa way out to the serosa. Okay, there's also another schematic diagram where you can see the normal intestines here. But you can see that the bowel, which has been affected in Crohn's disease, you can see that the wall appears very, very thick because of inflammation. Then you have your fissures inside there. You have the inside being ulcerated, and it appears like a cobblestone. Okay. So,
sir.
Yes. Hi.
Sir. Please, what's the word? Is it transmural?
Transmural.
All right.
Transmural.
Okay. Okay. Thank you.
You're welcome. So TRANSMURAL, transmural.
Okay. Okay.
Okay. I want to see if I can get you what's the cobblestone really mean. Okay. Call a cobble. This is what we call a cobblestone. Okay. So that's a cobblestone. So let's try and see. Cobblestone Crohn's disease. The real cobblestone is. Now we are trying to find. Okay. So can you see this picture? See, it's a bit similar to the actual stone that was projected earlier. So if you can see this.
Yeah.
So this is the inside of the gastrointestinal tract, so we'll say the mucosa, is showing the clear cobblestone appearance. Okay. Let's see if this can give us something classic. Okay, great. So let's use this picture. We'll be talking about ulcerative colitis pretty soon. But then with this picture, so you can see the normal healthy bowel here, as you can see. And what we talked about was Crohn's disease. And we said that Crohn's disease, there's an inflammation, and this inflammation goes way beyond the inside and it extends to the outside. You can see how the outside looks the normal. However, the outside here, which is the serosa for Crohn's disease, doesn't look so normal, right? And then let's look at ulcerative colitis, which we'll be talking about shortly. You can see that the outside looks normal, and the issue is just the inside or the mucosa. That's where the inflammation is. Okay, do you get the idea?
Yes, sir.
Yes, please.
Okay, great. Great. So this is also basically another diagram which will be coming to in a bit. So you can see the normal, and then on histology, you can see the normal thing that we expect to find here. And then this is when you do your endoscopy. And then when you look at the Crohn's disease, you can see that the inflammation extends all the way, affects the muscle to the outside. Okay, you can see that the wall looks thickened and the inner aspect looks narrow. That's a classic thing about it. It has a thickened outer wall because of the inflammation, and because the inside is also undergoing inflammation, it becomes what? Narrow. Okay, so that's what you tend to find. And then you have the classic cobblestone appearance in there. Okay, whereas ulcerative colitis is just going to be the inside where your issue is. All right, so let's go back to our slide. Okay, so
Doc.
yes, please.
Please, in both cases, will you see maybe bleeding, or it's only in the ulcerative one that you see bleeding?
Okay, okay. So let's touch on the ulcerative colitis, and then you can compare both. Okay, afterwards. We'll try and compare both afterwards.
Okay, thank you, sir. Thank you, sir. Okay, sir. Okay.
So as you can see, we've talked about this here. So microscopically, you can find that with Crohn's disease, all areas extend to all the layers. So we say it's transmural. And then, of course, because you're seeing there's an exaggerated inflammatory response, you can see, and it's a chronic condition. So chronic inflammatory cells, a lot of them, and then the lymphoid tissues to become a bit bigger. Then you would have, once you have chronic inflammatory cells, the whole chronic inflammatory process, you are going to have lots of macrophages being recruited. When you have aggregation of macrophages, we call them granulomas. Okay, so when a macrophage, you have a lot of macrophages coming together, then we say that there's a granuloma that has been formed, as you can see. And then we have something we call goblet cells, and these goblet cells are responsible for producing mucus, okay, in the normal GIT tract. And in Crohn's disease, granulomas are present, goblet cells are present, and then crypt abscesses are present. this goblet cell here is key because as we go on, you realize that the other condition might not or won't present with goblet cells. So it helps in making a diagnosis in terms of histology. So it would help you, okay, in Crohn's disease, you can see granulomas, you can have goblet cells and crypt abscesses, whereas in ulcerative colitis, this and that is what is present, okay? So, what are the features or the clinical features? So about 15% of patients won't show any symptoms at all. And the rest would have some form of abdominal pain because inflammation comes with pain. They are going to have diarrhea, and this diarrhea may be bloody or non-bloody. Once mucosa is involved, most likely when you poop, there will be some speck of blood or mucus in the stool. Then it's not classic. It's not a classic thing that whenever they go and they use the washroom and they poop, they should have blood in the stool, but it's something that can happen. Then because of the whole diarrhea, there's a risk for weight loss. And then they also become anorexic as well, okay? Once you read further, you realize that it's not all about diarrhea, because if you are getting chronic inflammation for a very long time and eventually you develop some sort of strictures in your gastrointestinal tract, then what will happen? You are going to move from that diarrhea and you are going to develop constipation sometimes because of that kind of stricturing you develop secondary to the inflammation, okay? And once you get constipated, then there's the possibility that you can develop an intestinal obstruction. When you have the stool staying there for a very long time, bacteria is going to work on the stool, is going to break it down, and then you are going to develop some sort of diarrhea from that as well. Okay, so it's like a vicious cycle that keeps going. So patients are also nausea, and sometimes just because it's not only localized the gastrointestinal tract, they can also have what we call extra intestinal manifestations, okay? So sometimes they have joint pains, they have sores in the mouth, we call aphthous mouth ulcers and all that, okay? Investigations. So there's no one single investigation which would point you and say that this is Crohn's disease, okay? Investigation is basically sort of, it's supposed to just help you so that you find out if there are any other extra intestinal involvement. It's also supposed to help you to see if the disease condition is severe. It's just supposed to direct you to a certain path. Okay, so clearly if someone has Crohn's disease and the person is, pooping blood, then clearly the person would lose some blood. You expect the person to be anemic and can sometimes tell the severity of a disease based on the anemia. ESR, CRP, those are inflammatory markers because we are talking about inflammatory bowel disease, so they'll go up. Mind you, most of these investigations are basically similar to what we'll be talking about when we get to ulcerative colitis. Okay, it's just one big topic and it's subdivided because one is restricted to only the mucosa, whereas the other goes through the mucosa to involve the serosa. There's also an investigation called fecal calprotectin, which it can be done. Usually once they do this test and then they pick up calprotectin in your feces over a certain range, I think about 120, over that range, then it means that there's an inflammation going on in your gastrointestinal system, and it would help point us to the direction of an inflammatory bowel disease. Okay, because we are saying that it's multisystemic, and sometimes people will have Crohn's disease, can have liver involvement. It's good to look out for your LFT and your albumin levels. Also blood culture, because sometimes an infection can set in, so you can go ahead and do a blood culture. It will direct you. When it comes to imaging, we want to see exactly what is happening. So you can do what we call a barium follow through. We'll ask you to swallow something, which would basically delineate your GI tract, and then we take pictures. We take pictures of that, like x-rays of that, and then we can see the part that is inflamed, the part that has strictures and all that. I'll try and put up a picture so that you can see how it looks. And then you can do an abdominal CT scan with contrast. When the patient doesn't have very, very severe cases, you can go ahead and do an endoscopy. Because sometimes if it's that severe, bleeding and all that, an endoscopy wouldn't be the right thing to do at that particular point. If the patient is having GI bleeding and you think the patient has an inflammatory bowel disease, because when you go through at that point, because the bowel has basically become a bit soft, you can perforate and then you give the patient even more, serious problems. So it's not the right thing to do. And sometimes you can go ahead and then you do an ultrasound scan. It's a high resolution ultrasound scan. Let's see if we can get any picture for a barium follow through. Let's see how that looks. Okay, I hope you can see my screen.
Yes, sir, we can see it.
All right, great. So ideally, when you do a barium follow through, you expect that you see the whole diameter of the bowel coming out nicely. You can see where the arrows are pointed to. This particular area is showing what we call a filling defect. Okay, so you can see that this area didn't really fill nicely as compared to the way these other areas are filling. Another classic part is look at this side. See the way it's filled, but once you try to progress, there's some sort of narrowing of the lumen, which we talked about, and then it comes out again and it's fine. So this is an example of escape lesion. You have a normal bowel, then there's a lesion, and then there's a normal bowel. You get the principle. So when you do a barium follow through, it's going to give you something of this sort. And then you can go ahead and then you make a diagnosis. Okay. So let me see. So you can see another one. This part and this part is basically normal, but you can see that there's narrowing all the way here. Comes out, opens up, then there's sort of narrowing here, and it comes out. Okay, so this basically this what we've been trying to talk about. Once you do your imaging and you find something of that sort, then we can stick out our neck and say, okay, this is what we are dealing with.
Sir, can you repeat that again for me? I don't really get it. The barium investigation.
Barium follow through.
Yeah.
So the barium is acting like some sort of contrast where you take it in your mouth and then we would take images of that, like sort of x-rays and whatnot.
Okay.
You take images of that. And because it's a contrast, it's going to outline your GI tract from your esophagus all the way to when it comes down. It's called follow through. It's called follow through because you are following through from the top to the down. So we have what we call a barium swallow. And that one, we usually do those barium swallow when we want to assess just the esophagus and probably the stomach, okay? So then we'll ask you to swallow and then we'll take, and we have what we call a barium enema. We'll give it to you from your anus and then we'll want to see what is happening from your rectum and your colon. So that's a barium enema. Now, if you want to see what is happening from top to down, then you do a follow through. Okay, so patient takes it, ingests it, and then you take your images right from the top to the down. And then they will delineate. And remember, we said that Crohn's disease can happen from the mouth to the anus. So we need to do a follow through and then delineate all the portions that we have lesions there. Okay, and once you're seeing skip lesions, normal bowel, and even to the normal bowel, you have an abnormal bowel and whatnot, then it points you to a certain direction and it helps you make your diagnosis.
Okay.
All right. So basically that's it. You also clearly your abdominal CT scan with contrast will give you something of that sort. Okay, but this time around, that one won't be like a barium follow through where you're doing X-ray. This one, the image will be clear because you are using a CT scan to do it. Okay, so it's just the same principle behind that. So complications, you can develop an anal fissure because it could lead to, some sort of obstruction and constipation and obstruction. We know that you end up straining, you build up pressure and you can develop hemorrhoids as well. And we are saying that because there's damage to the mucosa and it comes all the way out, you can develop an abscess. Later, you can even develop a fistula because the damage isn't restricted to just the mucosa. It comes through the whole bowel, so it's transmural. Okay. And then, so basically this is you can develop a fistula in the anus or an anorectal fistula. And we are saying that you can have extra intestinal manifestations. So the joints can become involved. So you can have arthropathies, okay, which will come with joint pain and some abnormalities of the joint swelling, because it's an inflammation. So in a way, it's looking like something like some sort of autoimmune condition in a way, okay. But this is just a dysregulation of your system to bacteria in the GI tract. You can also develop what we call a pyoderma gangrenosum. This is like an ulcer which is basically discharging on the skin. It's common at the portion of your lower limbs. Okay, so when you Google pyoderma gangrenosum, you can find that. Then you can also develop a sclerosing cholangitis. Okay, cholangitis means that you have an inflammation of the biliary tract, and it's because we're saying the disease has extra intestinal manifestation. It can also affect the eye, so it can affect the middle layer of the eye, what we call the uveitis. So middle layer of the eye, that's where you have the iris, the ciliary body, the choroid layer. So you can affect that. It can affect the episclera and the sclera. So the episcleritis can also affect the conjunctiva. So basically that is the complications you can have. Management is based on trying to slow down inflammation, basically. So you are putting your patient on anti-inflammatory drugs, okay? So you can start with your usual oral prednisolone, and then in terms of diet, your patients will have to take a low-fat diet, and then a low linoleic acid diet for about a month. Okay, so this linoleic acid is commonly found in vegetable oils and whatnot. So you can do that. And then they combine that with azathioprine or 6-methactopurine. And you do this at the first stage. This is called remission induction. So you want to try and resolve, that's the first thing you do to resolve the inflammation. Then after you've done that, you want to keep the patient in remission. So you put a patient on some salicylates, okay? Sometimes you can give azathioprine, 6-methactopurine or mycophenolate. So your own is to be able to make this diagnosis, and then you refer the patient to a gastroenterologist. This is there for you to know that once they get to the gastroenterologist, this is what we are going to do. We are going to induce remission. We put the patient on anti-inflammatory drugs, and we give the patient some drugs to just slow down the whole process. So we give azathioprine, 6-methactopurine, and then afterwards we want to maintain the patient in remission. So we continue with our salicylates and then azathioprine. Okay. There are also other medications that you can give when the disease is very stubborn. You can give your monoclonal antibodies, okay, like the infliximab, and then there's rituximab and all that. And then you can also put your patient on methotrexate. Those ones are usually reserved for the very, very stubborn conditions. Okay.
Hello, sir.
Yes, please.
Yeah, particularly, I'm always concerned about answering of questions.
Yeah.
You said our own is to be able to diagnose and refer to the gastroenterologist for this treatment to be given.
Yes.
And so in the examination as PA, they ask, how would you manage this case? You don't have to mention that these drugs will be given.
Oh, you need to mention. The reason why I'm saying that your own is to diagnose and refer, you need to mention because you need to know. But then as in your field, as a PA, when you are given some medications, you need to be extra careful. If I make a diagnosis of Crohn's disease, what I will do, and if you also make the diagnosis, what you should do is to start the patient on the basic anti-inflammatory drugs like the prednisolone. The fact that you know that you give azathioprine to the patient is a plus for you because you are referring, and that's the reason why you say, I'm referring to the gastroenterologist for further management. Most of the time we say, I'm referring to this specialty for further management without even knowing what the further management would entail. And you should know this because before you refer your patient will ask you that, oh, Chief, I'm in front of you. So why are you referring me? You understand? And you say for further management, they would want to know what is that further management. Does it mean that they are going to give me medication or they are going to operate on me? So you need to know.
Okay.
You understand? So in the exams, if they ask you, you need to let them know that you know. But when you are practicing, I'm not sure you'll be comfortable prescribing azathioprine or 6-methactopurine for your patient to go and buy because it comes with a lot of side effects. And once your patients are on these things, your patients will need constant monitoring. So your own is, you know, but that's not what you are not going to refer the patient for further management, and you know that is what is going to be done during the further management.
All right. Thank you, sir.
You understand? Yeah. So even with the STGs, prescribing most medications are restricted to a certain level. Like you can't just get up and give a patient methotrexate because you think that the patient has Crohn's disease. You can only do that after you have discussed with the specialist. So some medications are more of specialist level, and then some other medications are on our level that we can all give whilst they are awaiting specialist treatment. Okay.
All right, thank you, sir.
You're welcome.
Hello, sir. So the Crohn's disease is more of like an autoimmune something, or
Yes, but
if I
then
get you right.
we don't classify it as an autoimmune condition.
Oh, okay.
We don't classify it straightforward as an autoimmune condition. We are saying that it's more of a dysregulation of the inflammatory system, where you are making excess white blood cells to go and fight something that you could have fought with less number of white blood cells. You understand? So you are making a lot of inflammatory cells, and these inflammatory cells would go through processes, recruit more inflammatory cells, and you are going to have excessive cytokines being produced. And these cytokines, even though they may have a positive effect or a good effect if they are being produced in smaller amounts, because you are having a dysregulation of the immune system in terms of this cytokine production, you are now going to have something excess being produced. Okay, and that is what is going to lead to the destruction of the tract. And it's not just Crohn's disease, it's the same pathophysiology for ulcerative colitis too. Are we okay?
Yeah.
Yes. So the main features is what differentiates them. Pathophysiology is the same, okay, or it goes along the same line, but then the distinguishing feature is the fact that we are saying Crohn's disease is transmural, and Crohn's disease can happen all the way from the mouth to the anus. You won't get ulcerative colitis at the ileum. As the name suggests, it's colitis, so you won't get it there. Okay, the closest you can get is what you call a backwash ileitis, where if you have the ulcerative colitis, which means that the colon is inflamed, right? So if you have the ulcerative colitis, probably you have ulcerative colitis, so you can follow the arrow affecting the side all the way here, or maybe affecting the ascending colon here. Okay, then sometimes because it's inflammation, you can have it affecting this small part of the terminal ileum. That's the terminal ileum. So it can affect this small part. So we call it backwash ileitis. But the inflammation is not coming from the terminal ileum to the ascending colon. It's rather going back. The inflammation is in the ascending colon, but it's rather going back to affect some small parts of the terminal ileum. And that's what we call backwash ileitis. But classic presentation, as the name suggests, is a colitis. So it is restricted to the colon only. Okay. So basically that's it. If it affects the rectum, we call it proctitis. If it extends and affects the sigmoid colon, then it becomes a left-sided colitis. If the inflammation goes all the way from the rectum to transverse colon, eventually ascending colon, then we call it total colitis. It means every part of the colon has become affected. Okay, so macroscopically, the outside and everything looks fine, unlike Crohn's disease. Okay, but then the main issue is with the mucosa, which looks reddened, it looks inflamed, and it bleeds easily. Okay, so your patients would have diarrhea with blood in there. Okay, and unlike Crohn's disease, as I said, where you can have the skip lesions, this one, inflammation is usually continuous. You don't have a break in there and then there's inflammation going on elsewhere. The inflammation will follow and then it's continuous. Okay. So also here in severe disease, the mucosa is lost. You have a few parts of the mucosa, and even this would appear inflamed, and then it looks, the whole bowel might appear toxic. Okay. So with ulcerative colitis, we're saying that a mucosa, because it's just a mucosa, it can return to normal on healing. However, sometimes there's distortion of the glands in there. So if you look at this schematic diagram, you can see the outside looks fine. The problem is the inside. You can see it's all ulcerated, looks raw. Okay. In terms of histology, you remember we said that Crohn's disease, there are crypt abscesses, and then there are lots of goblet cells present. Ulcerative colitis will have crypt abscesses, and then they will have no goblet cells. Okay, so there'll be depletion of goblet cells in ulcerative colitis. Remember Crohn's disease, we said you have macrophage aggregation and it forms a granuloma. Ulcerative colitis, you won't have that. So these features would help you distinguish if you are not so sure whether, oh, maybe this one is the Crohn's disease, it's now starting. So maybe that's why it's just in the mucosa. You can look, you can use the presence of goblet cells and granuloma to help you make that diagnosis when you do your histology. Okay. Clinical features, they are going to have bloody mucoid diarrhea. They have pain. You can see that all these are signs of inflammation. They have joint pains, then we can run a temperature, they vomit, they're anorexic, weight goes down because they basically won't eat because of the anorexia. They can also have aphthous ulcers. When attacks are severe, or when do you say that ulcerative, for a patient with ulcerative colitis is having a severe attack? If they present to you and they are stooling about 6 times or more, it's a problem. If the temperature is going up, there's a problem. If their pulse is going up, there's a problem. Okay, so you can see that with the pulse going up, it tells you that the patient is becoming septic, and sepsis can actually lead to shock. So as a form of compensation, the pulse goes up. Okay, and it's very easy for them to go into sepsis and shock. Then you can see other inflammatory markers like ESR also going up. If the HB is falling below 10, you are worried. If the albumin level is below 30, you are worried, because remember we said something about extra-intestinal manifestation and the liver being one of the areas where you can have it being caught up when you have your ulcerative colitis. You can have an extra-intestinal manifestation, so liver enzymes can drop, and then, liver function can drop, albumin would also fall when liver function drops, because the liver is expected to be making albumin. So when the function falls or drops, albumin level will also fall or drop. Complications, so bowel can get bigger, you can have a toxic megacolon, you can develop the extra intestinal manifestations we talked about, like so the joints, you can have pyoderma cavernosum, you can have sclerosing cholangitis, which we've talked about, uveitis, episcleritis, conjunctivitis, which we've talked about. As part of the management, you realize that sometimes you will need to do surgery for the patient. And in doing the surgery, you are going to remove the disease part of the colon. And once you remove it, we say you've resected it. It's called resection. So you've resected it. And after you resect, you need to join a fresh part. So let's say if you are removing the colon and you've done a resection of the colon, you need to come and join the ileum to the, a distal part of the rectum or the anus. So you need to come and bring it all the way there, okay, to form some sort of anastomosis. And once you do this, you can develop something or form something that we call a pouch, okay, as part of the surgical procedure. With time, this pouch can actually get inflamed. Okay, it's one of the main complications when you do the surgery. So when you go and then you remove and then you do an ileoanal anastomosis, bringing the ileum to join the anus, then you can sometimes form something there, and then you can have what we call a pouchitis. Okay, that's what pouchitis means. So investigations, basically the same, similar to what we've already talked about. So full blood counts, because HB is key, and WBC levels will tell you if this patient is septic. Inflammatory markers, ESR, CRP, also the fetal calprotectin we talked about, Then LFT, you can also look out for anti-neutrophil cytoplasmic test, or called perinuclear anti-neutrophil cytoplasmic test. It sometimes goes up when you're dealing with ulcerative colitis. Then a stool culture would also help you as part of your septic screen. An abdominal X-ray if you are suspecting there's some sort of obstruction, because chronic inflammation, as I said, will lead to stricturing and narrowing of the inner aspect of the GIT. So with time, you can actually develop an intestinal obstruction, and that's where your plain abdominal X-ray would help you. We do a plain abdominal X-ray, erect and supine, and then it shows us if there's any form of inflammation. Then an abdominal ultrasound. In severe attacks, as I said, try as much as possible to avoid putting an endoscope or a colonoscope in there, because there's a risk of perforation. Okay. Management for ulcerative colitis, we would usually want to put them on the salicylates. Okay, so we do a combination of the salicylates and then a steroid, which is anti-inflammatory. So a bit similar to what we talked about. So the steroid can be an oral preparation, or it can be a rectal preparation. Okay, so it's supposed to be with oral or rectal steroid preparation. Okay. And then if it's that severe, where we say you have a total colitis, we would usually admit you, and then we would want to do the steroids IV, 100 mg every 6 hourly. And then we'll switch to prednisolone once response has been achieved, okay, whilst you are still on the salicylates. As I said, our role is to know the kind of medications to give, but then in terms of prescription of some of the medications, you need to refer. Of course, hydrocodone, prednisolone, those ones are medications that we can give. But this patient, because it's actually going to be a chronic condition, the patient will need to see a specialist. We need to see a gastroenterologist, because it's a big thing, and you can't just manage on your level and you ask the patient to be coming for reviews without referring. You need to refer your patient for a gastroenterologist to also assess. When medical management fails, there's a role for surgery to come in, especially when inflammation is that bad and we need to do we need to actually remove the colon. So we need to do a colectomy, or we need to remove the rectum and the colon, or a proctocolectomy. Surgeons would have to come in, and then they will do that as well. If the bowel perforates, you need a surgeon to come in to come and do a resection and an anastomosis. If it's bleeding, you will need surgical review. Okay, so these are some of the times where you need to get a surgeon to intervene. If you haven't referred your patient to be managed by the gastroenterologist and you keep seeing, and these complications come up, then it becomes difficult, because now you have to go and get a surgeon to manage. But if you're managing with a specialist, then it's more of a specialist interaction, and then patients will get sorted out early. So apart from your steroids, your salicylates you can give, of course, you can also put the patient on antibiotics, even though research has shown that if infection is not so bad, you risk causing some sort of antibiotic resistance when the patient really needs the antibiotic. So we need to be cautious, and that's where the blood culture we were talking about in terms of investigation comes in. Okay. Then we mentioned immunosuppressants already. So there's a thiopurine, methotrexate, and all that. if we are saying that you can have your Crohn's disease from up to down, so if it's affecting the stomach and there's inflammation, then it means that you can, just as we talked about peptic ulcer, you can give your H2 receptor blockers or your proton pump inhibitors. Okay, very, very, very key. In a situation where they have severe abdominal pain, your antispasmodic agent will come in. So you can go ahead and then you put your patient on your dotaravin, which is Nospa, or hyoscine, which is Buscopan. Okay. So that is inflammatory bowel disease for you. That's all we'll be talking about today. Time is a bit fast spent, so I'll take your questions and then we can end the class and prepare for tomorrow.
Yeah, so I have a question.
Yes.
Doc,
Yeah, so one after the
please,
other.
can you do PPI? Okay. Can you do a PPI with the A2 receptor antagonist together, or you have to do them separately?
You can combine sometimes. Because they are both going through different means.
Okay.
Yeah.
All right.
I wanted to ask what definitive feature will make you do the diagnosis for the first time so that you don't miss it?
Okay.
It's likely similar to other conditions like diarrhea and those stuff.
Exactly. So that's a good one. So once this condition falls under your chronic diarrhea, so you have a acute diarrhea and you have chronic diarrhea, okay, or acute GI manifestations and then chronic GI manifestations and symptoms. If you have a patient who one-off comes to you and then has diarrhea with blood in it, we go ahead and do investigations, do our full blood count, we do a stool RE and a stool culture. Okay, it would help you. It would tell you, oh, okay, there's an infection, or the stool culture came back. We saw some amoeba in there, so we think that this is amoebic dysentery. Okay, or when the stool culture came back, it picked up some Shigella, so we know that this is shigellosis, which also causes blood in the stool. Okay, so your initial acute investigations would suffice for your acute infections. However, patient comes, you are not so sure, investigations are fine for the first time, and then you go ahead to manage as dysentery. However, your stool RE comes back, you didn't pick up any bacteria and whatnot. No problem, you've given antibiotics, it's resolved, ciprofloxacin, patient goes. And then patient comes back again. And then you realize that in a year, the patient is having this condition and it's a little bit more recurrent. And patient, you've counseled patient, don't eat out. The patient is telling you, I'm eating from home and all that. That should prompt you and it should tell you that, okay, this is not just an acute condition where I think this is something like a gastroenteritis, because the patient has been having this diarrhea. Most of the time, even before they come to you, they will tell you that they've been having this for a very long time. And that's why history is key. Whenever you see your patient and you ask, oh, when did this start? And the patient tells you that, oh, this is my diarrhea with blood in it. I've been having it for like 3 years, so it's on and off. Then you know that this is not your usual gastroenteritis. So it means that people have been missing and been managing as gastroenteritis. The onus lies on you to go further beyond that and look out for these things that we've talked about and do investigations to help you make that diagnosis of inflammatory bowel disease.
Okay, thank you.
You're welcome.
Hello, sir.
Yes.
Yeah, please, which sample is worked on microscopically to determine whether the gallbladder cells are there or not?
Oh, you take a biopsy.
Yeah, so how do they take it? Because you say you don't have to pass colonoscopy or endoscopy. So how do they take the biopsy?
No, I didn't say you don't have to pass. I said you don't pass in very severe conditions or when they are having a flare of the disease, because by then you are sure to have the risk of perforation. But then, as I said, it's a chronic disease, so it's not like throughout the whole year they are having this. They have moments where they are in remission, or it goes down, and then there's a moment when it relapses and then they flare.
Okay.
And that is why your gastroenterologist will help. After you diagnose and your gastroenterologist puts on treatment and it subsides, he would want to see exactly what is there. So he would pass an endoscopy or a colonoscopy to see what is happening there. At that point, you can actually take a biopsy and see if it's actually regenerating. Because remember, we said that with ulcerative colitis, you can have some form of regeneration. So at that point, they can take a biopsy and see the kind of damage that has been done and if there's any improvement. Okay.
All right. Thank you, sir.
Sure. Any more questions, please? Okay, so let's try and go over slides. I think there are about some few GI topics to touch on, but when we are having a full session emergency medicine lecture, we'll talk about that, like the acute cholecystitis and all that. So tomorrow, God willing, we'll start renal, and I'm hoping next week by Sunday we should complete renal, and then we'll move to a new system. Okay. If we are able to maintain our 3 times a week session, I'm hopeful that by the end of August, we should be done with our lectures and then we can prepare for exams. So enjoy your evenings, and let's meet God willing tomorrow. I'll communicate a time to your class reps. Okay.
All right, Doc. Thank you very much.
Thank you, sir.
You're welcome.
All right. Have a good night, Doc.
You too. Good night.